sampaikan, which would be related to your practice, which I think need to be conveyed. Yeah. So basic sciences ni, I think it's not essential as long as you know now there are about 700 red cell antigens. Yeah. So in 2014 they say about 300. Now I think easily can be around 700. But then again, yang important will be the ABO and research for you. All right. In fact, they are really grouped into system lah, yeah. So these are among the system, and in each system you can have banyak. And so you see research yang you all tahu is just D antigen, but actually there are about 49 research antigen, yeah. So there are many. So leave the rest to us, yeah. All you have to know is the ABO and research. All right. Most of these antigen are protein, but some can be carbohydrate structure, yeah, on glycoprotein or glycolipids, right? So most important clinically will be the ABO. And remember, yeah, ABO gene, just for your basic science, you've learned this in undergraduate. A gene, B gene does not code for A antigen or B antigen. Please remember that. Yeah? A gene, B gene codes for enzyme that we transform the H substance on the surface of the red cell by addition of this molecule, galactose and acetylamine, and convert the H substance to become A or B antigen. All right. Okay, you should know by now that, you know, most common blood group will be O, yeah, in our population, yeah. Of course, you have more Bs, yeah, among Indians, all right. And the other thing is, in our population, Indian population has the highest rhesus negative, lah, yeah. So if you see in the study, it's about 8.3%, right? So when you have a rhesus negative patient, yeah, to you it's just D negative, right? So there's absence of this big D, yeah. So in the lab, once we have somebody who is D negative, we will also type for big C, little c, big E, sorry. Okay, we will also type for D, big C, big, this one we do routine, but once you have a D negative, which is designated as small d, then we will also do all this. That's why when we ask you to send for rhesus phenotyping, then you have to understand that the patient is already D negative. In the lab, we want to type for this other rhesus antigen. Why is that important? Once somebody is D negative, we also have to give the other, we have to give the blood that also match with the C antigen and the E antigens. Yeah, just remember that. So rhesus phenotyping means you have to send blood to the lab for us to type for these other important antigens. All right. Okay. All right. Because we have many patients who actually have anti-E. So when you send for antibody screening, then we say, okay, antibody is positive, we need to send for antibody identification. Most of the time will come back as them having anti-E. But these are the patients who are not D negative, right? Okay. So ni tak apalah, you all baca sendiri, yeah. I just want, so the other antibodies, yeah, anti-C, anti-little c, big E, semua ni pun can cause hemolytic transfusion reaction, can cause hemolytic disease of the newborn, yeah. The other antibodies, these we will actually be more careful to type for this antigen for thalassaemic patient, especially the Cal, Duffy, and the KIT, because these are the antibody that they can form later with repeated transfusion, right? Okay, most of the time the other system apart from ABO dengan research, they are not important. You just have to remember this for two things. One, the other system, they have low antigenicity. What does low antigenicity means? It means that if you don't have the antigen, and you are exposed through transfusion with the antigen, the likelihood that you develop antibody is also low because of the low immunogenicity. Now, the other reason why you don't or you rarely develop antibody to all the other antigen is because they are of low frequency, which means not many people in the population actually express the antigen. And therefore, the likelihood that you get immunized with this antigen will be low, right? if you can understand that lah. Yeah, all right. So these are the other antigens that you can look through. All right. Now, I just want to stress to you that there are two forms of antibody in transfusion medicine: the naturally occurring and the immune antibody. When it comes to naturally occurring, you know that they are anti-A, anti-B, and they are of IgM class. Because they are of IgM class, they are cold antibodies. Because they are cold antibodies, they react best at 4 degrees. But because they have a wide thermal amplitude, they can also react at body temperature, so that dangerous. All right, because IgM can fully activate complement, leads to formation of membrane attack complex, and can cause intravascular type of hemolysis, which is more dangerous than the extravascular type. The immune antibodies, others are generally immune antibodies, which means you have to be exposed. Let's say you don't have D, you have to be exposed to D antigen first. How? Through previous transfusion or through pregnancy. All right. So then you develop IgG. IgG is a warm antibody. Because it's a warm antibody, it generally does not fully activate complement. Therefore, you don't get intravascular type of hemolysis. You get extravascular type of hemolysis. I'm going to skip some of this. You can read on your own. I want to stress on this. Cross-matching, the basic sciences behind it, you have to understand so that you understand what's happening in terms of transfusion medicine. You have the group cross-match and the group screen and hold. I've mentioned this a few times. Yeah, I just wanted to stress to you that the Ministry of Health indicator for the standard of transfusion practice in a hospital. One of the indicators which we have to report is the cross-match to transfusion ratio. The national cross-match to transfusion ratio is set at 2.5:1. What does that mean? That means for every 2.5 requests of cross-match, you can read as 3 or 2, yeah, there should be 1 transfusion. If the cross-match to transfusion ratio exceed this, which means it's 10:1, or meaning that for every 10 requests of cross-match, you only have transfusion, only 1 transfusion, that is excessive request for cross-match, which actually reflects on the standard of transfusion, which means that you don't discriminate. You just simply ask for cross-match for everybody. Yeah. So what is the impact of that on us? Yeah, the impact of that on us or on blood bank is basically when you send for cross-match, we will reserve for 48 hours and then you don't use, right? So that will cause, the artificial shortage of blood. It causes prolongation of the blood, yeah, because you cross-match and then you return to the general pool, you cross-match, you return to the general pool. It can go, it can lead to expiry of the blood product, and of course it leads to increased workload. And that's why that brings us to GSH policy. Again, you cannot misuse the GSH, yeah. There are some cases that you need to send for group cross-match. You cannot send for group screen and hold, all right? So in group so let's look at the tests involved in group screen and hold. We do the ABO and we do the antibody screening. That's all. If you send for group cross-matching, we proceed with cross-matching. Yeah. So this is a grouping we do. We do tube grouping. Yeah. This is positive. Yeah. This is positive. This is negative. But now, but some lab we used to use this gel cut. It's very much easier. It's so objective. This is negative. When it's up there, it's positive. You've done the practical. Yeah, the student, I'm not sure during your time you have this gel cut or not. I presume yes. All right. So here it will be what? So positive. So B positive. So reverse, it has anti-A positive and it's D negative, right? It's so clear cut, but it's expensive. So we don't use gel cut anymore for grouping. Now for grouping, we use group cross match, right? So when we do antibody screening, basically we want to look for, does the person have antibodies other than the anti-A, anti-B tadi? We don't look at that. Other antibodies, anti-big E, anti-big C, or anti-Cal, and all those that can cause hemolytic transfusion reaction. So what do? We take the patient's plasma and we cross-match with reagent red cell. These are the red cells that we buy that express clinically significant antigen. Therefore, if the patient's plasma has significant antibody, the antibody will bind to the antigen on this red cell and will cause agglutination, and that will tell us there is antibody. That's why, so we will call you up and say the antibody screening is positive, right? Okay, so the basis of this antibody screening is indirect Coombs test. All right, so when the antibody screening is positive, we have to proceed to antibody identification, right? So we'll tell you that, okay, please wait, we need, because once antibody is positive, we need to identify what's the antibody, and we have to look for antigen negative unit. Yeah, but sometimes the scenario is when we say group screening is positive, there's antibody, you cannot proceed first, you have to wait for us to get the blood, because we have to convert to cross-match because of this antibody, because just in case there's bleeding, then we have no blood to supply. But then the story will turn the other way and say, actually, we can do without the blood, right? We can do without the blood, so we can proceed. So they will proceed, but then we will tell you, we will not be able to actually give you the blood that you need in time. Yeah, but we still, our rule is we have to proceed with the antibody identification. We have to find out what is the antibody in the patient. Yeah, so if there's no antibody, then we just keep the plasma, and then when you need, we just cross-match, all right? Now, you should not send for GSH when, for example, the patient is severely anemic, the patient is having bleeding, all right? Or there is a high likelihood that, you know, you are going to use blood for that particular surgery. Then you must send for group cross-match, yeah? Why? Because there is high likelihood. So we'll reserve blood for the patient. Or you cannot do GSH in somebody who is known to have red cell antibodies, or who is known to have rare antibodies, not rare, uncommon. For example, in somebody who's rhesus negative going for surgery, you cannot send GSH. You have to send group cross-match, because rhesus negative we don't keep in the stock. What we have to do, we have 1 or 2 for emergency use. Otherwise, we have to call the donor and we have to collect the blood, right? So you cannot use GSH for this kind of situation. Or transfusion dependent patient, for example, thalassemia patient, you cannot send for GSH. You've got to send for group cross-match. Why? Because transfusion is definitely going to be utilized. The second thing is they have high likelihood of having antibodies. We don't practice GSH as well in pediatric patient, and of course in emergency. So you cannot misuse. So these are just some of the antibodies that can be detected on antibody screening. Yeah. What is the percentage in the general population that they have antibodies? Is around 1 to 2%. All right. Okay. So this is just to show you how we do. This is negative, remember? So we do with the screening cell. Yeah, screening cell 1 and 2. This is negative. This is negative. But you see here, this patient, here is positive with screening cell 2. What happens is that when you have antibody, the antibody will bind to the red cell and they will form agglutinate. This agglutinate, when you centrifuge, they cannot go through this gel column, yeah, because they are large molecules. So they are stuck up there. So that would reflect the positivity of the test, right? Okay, so now in group cross-matching, we add another. If you ask for group cross-matching, we do the same thing and we just do additional cross-matching, all right? So when we do cross-matching, we match the patient's plasma with the donor's red cell. It's no more reagent red cell, all right? No agglutination is compatible. If there's agglutination, it's not compatible. If that is not compatible, then we have to suspect the presence of antibody. We send for antibody identification. If you are still alert, you're not sleeping, then it will cross your mind, tadi kan dah buat antibody screening. Why it's negative? Why now it's not compatible? Kan? If you are wide awake, right? So why can this happen? This can still happen because the patient may have antibody towards antigen that is not expressed by the red cell reagent that we buy. Yeah, because we are Asian population. We buy the red cell from the Western population. right? So it may still happen. That's why we have not dropped cross-matching. But, you know, some bigger labs abroad, they have actually dropped cross-matching. They don't need, because they are confident with their antibody screening, all right? So this will be the workflow. Once we cross-match, we will hold the unit for you for 48 hours. Yeah, this is just to show you, all right? Now, I'm going to browse through this, gloss through this. You know this, you are already practicing. When it comes to whole blood, I just want to reiterate again, in a whole blood, the only thing you get from a whole blood is red blood cell. That's all. You don't get white cell, you don't get platelet from whole blood. Why? Because they are all dysfunctional. Yeah, platelet, white cell, the lifespan from the point of collection is only about 8 hours. So it's not functional. The platelet, because we saw the whole blood at 4 degrees, platelet cannot be exposed to low temperature. We saw platelet at 20. Yeah, that's why when you collect platelet, you don't put ice in the box. The moment platelets are exposed to 4 degrees cold temperature, they become dysfunctional, right? So the only thing you get from whole blood is just a red cell, right? So I just want to stress again, packed red cell, yeah, we encourage people to use packed red cell. It's the same as whole blood, but there's no plasma, all right? Okay, it's the same thing. All you get is a red cell, all right? So again, when you decide to transfuse, yeah, of course, you have to weigh the benefit and the risk. We have already distributed the guideline. Now, the guideline will stay as a guideline. You have to actually consider the case as a case and look at the case individually. Yeah, so the guideline is just to guide you. Yeah, so you have to assess the patient clinically. That's why when you need transfusion, especially red cell transfusion, we in the lab, we are not seeing the patient. We don't know how urgent you need the blood, whether it's not urgent or whether it's later. So you have to give the impression of how urgent you need the blood. Yeah, all right. Now, I think we have had the seminar on recently, transfusion seminar. I think maybe you all also were part of the seminar. So we presented on patient blood management, and I'm sure you're familiar with the concept. Yeah, soon perhaps Dr. Ismail will be starting the patient blood management clinic, the PBM clinic. Yeah, so the clients will be, of course, a surgical department, ONG department. Yeah, so he will be drafting the flow chart, yeah, of how to refer, when to refer, and all that. Yeah, so what is it? Yeah, if you don't know, it's basically it's a program to identify patients at risk of transfusion and to have a plan for the patient to basically reduce or totally eliminate the need for transfusion. All right. So the principle is basically to optimize the erythropoiesis. If you need to give iron, we give iron prior to surgery, and minimally invasive surgery to reduce the blood loss, and also to actually make full use of the patient's physiological tolerance to anemia, especially in the setup of patients where patients do not have cardiovascular respiratory problem. All right. Okay, so if you see in any presentation, this will be the pillar lah. Optimize the patient's red cell mass, minimize the blood loss, and also harness the physiological tolerance. And people will always quote this study when they talk about PBM, where it's done on a large group of critically ill patients. So they randomize 2 groups, yeah, that require transfusion, either the liberal group or restrictive group. One is the cutoff is at 10 gram. The other one is the transfusion trigger at 7, less than 7 or less. Yeah. So the outcome, yeah, they found that the outcome was better in the restrictive group. So it means that, transfusing the patient more does not lead to a better outcome. All right. So why do we need PBM? We need PBM because our donor pool of patients are not increasing, as much as we are recruiting the donors in, there are also many who are leaving the donors pool. Why? Because of age, because of diseases, all right? And of course, because of the direct cost related or direct or indirect cost related to transfusion, all right? And then you see here, transfusion has been, shown to be associated with increasing evidence of high morbidity and high mortality. And of course, we always will have this emerging and re-emerging pathogen, which we may not know now that will be a problem later. All right. So in surgical patient, the main risk factors that have been, recognized or already documented to be associated with increased risk of transfusion will be pre-operative anemia. That's why in PBM you maximize erythropoiesis, yeah, all right, and the volume of surgical blood loss. This is intraoperative, and the fact that you fail to actually, refer to the physiological tolerance of the patient to anemia, which means you use a higher transfusion trigger. Yeah. So these are the three factors that have been. So generally, in most published guidelines, say that transfusion in patients with hemoglobin level of more than 10 grams is almost never indicated. Yeah, a transfusion trigger of 6 to 7 for most stable patient, and for 7 or less when there is evidence of ischemia, ongoing blood loss, or other, like the cardiovascular or respiratory system, compromise or disease, right? Okay, so with platelet, you have to remember the point that I want to stress here is platelet, the shelf life is only 5 days. Now, for platelet, we don't cross-match, we just give ABO compatible because the shelf life is 5 days. Yeah, so we sometimes short of group compatible, so we do practice giving non-group compatible, but that is not encouraged. And of course, 1 unit of platelet can increase the platelet count to about 10,000. That's the maximum. All right. So when do we give platelet? You should know this. In patient with bleeding or platelet dysfunction, do we use prophylactic platelet transfusion? Yes, we use. Yeah, especially in patient undergoing chemotherapy. Yeah, patient with hematological malignancies, and the platelet transfusion trigger generally the acceptable now is less than 10. Yeah, for those with chronic stable thrombocytopenia, we don't unless the patient has bleeding, all right, or when the patient has superimposed infection. Yeah, we do give prophylactically for surgery or in the IC. In the IC, yeah, we discourage you to use that recipe. Yeah, I mean that is actually not encouraged anymore, but we still get the 642 regime. No, you look at the patient. If the platelet count is above 50, then above 50, you don't need to give. Maybe you want to tackle the coagulation factors deficiency, or in the absence of bleeding, you don't give the IC, yeah, because basically it does not. I will talk about this later. All right, when you transfuse somebody with platelet, all right, you need to assess a response. Now, the best time to do the response to see whether there is any increment is 30 minutes post-transfusion. There is this terminology that you need to know, platelet refractoriness. That's why we discourage you to actually transfuse platelet. Yeah, if we are not talking about prophylactic platelet transfusion in patient with hematological malignancies or patient going for surgery and all, if the patients are not bleeding. Why? Because there can be platelet refractoriness. You have to understand, we only give you ABO compatible platelet. We do not do cross-matching for HLA. Yeah, so if the HLA antigen is incompatible, you can end up with platelet refractoriness, which means now the patient is not bleeding, you give, for example, the platelet. The next time when the patient is really bleeding and you actually need to transfuse the platelet, you will not see the increment. That is what is meant by platelet refractoriness. Or there is a risk of platelet refractoriness when we give you ABO non-compatible platelet. But then when we have no choice, we have no choice, right? So there are other causes. So you have to understand this concept of platelet refractoriness. Yeah, the time that you really need the platelet to increase, you already have platelet refractoriness. Yeah, so you will not get satisfactory increment of the platelet. All right. You know about fresh frozen plasma. Yeah, it has all the coagulation factors. You see, we keep at -30. So when you request, we will thaw. The moment you take to the lab, if you decide not to use when you return to us, we just have to throw it away because we cannot freeze it again. Yeah, all right. So again, it's bleeding due to coagulation factors. All right. The same thing, cryoprecipitate, but cryoprecipitate is actually made from the FFP, and what you will get is a concentrated factor 8, von Willebrand's, fibrinogen, fibronectin, and factor 13. Of course, it's commonly used in DIC patient when the fibrinogen is generally less than 1 gram. Yeah. Okay, of course, in von Willebrand's factor, because we don't have von Willebrand's factor concentrate, or in factor 13, but not for factor 8 anymore. Yeah. Cryosupinatant will be whatever precipitate that you take from FFP, you have the precipitate that is cryoprecipitate. Whatever supinatant that you don't take that is cryosupinatant, you can still use for liver disease patient. All right. Now, you know, many studies, if you go into the literature, it says this. Yeah. The predictive, it states that studies have looked at the predictive value of PT and APTT in a variety of clinical state and determined that PT and APTT are not predictive of clinical bleeding. So you don't simply transfuse somebody, let's say with chronic liver disease, if the patient is not bleeding, just in the hope that you will prevent the bleeding. No, it does not. Yeah, it's not. If you correct, they're not predictive of, which means if it's prolonged, it does not predict that there is higher risk that the patient is going to bleed, unless the patient is going for some surgical intervention, right? Okay, and they have found that studies have looked at, you know, utilization of blood and blood product. Yeah, they have noted this point, inappropriate use of FFP, yeah, based on the assumption that PT and APTT are predictive of bleeding. So FFP is given to normalize this test with the hope that it will prevent bleeding, right? Okay, so clinical indication, of course, you know, some people also use in hypovolemic state to reverse a prolonged INR without bleeding, or as a source of albumin or nutrient. We have albumin concentrate, so you need to use that. All right. Okay, this one you can read yourself. Yeah. You can read. Yeah. Yeah. I just want to this guideline. Yeah. Guideline. This is from the British Society of Hematology. The guideline for DIC. So it says here is transfusion of platelet or plasma in DIC patient should not primarily be based on lab result, should in general be reserved for patients who are bleeding. All right. And in patients with DIC bleeding or at risk of bleeding, yeah, then you would want to, like for example, they're going for surgery, post-operative, or for invasive procedure, then you would like to maintain, yeah, the platelet count to be above 50. All right. Okay. So platelet count trigger, platelet transfusion trigger will be 50 and less. Right. So in non-bleeding patient DIC, prophylactic platelet transfusion is not given. Yeah, unless the patient is having infection, for example. All right. And in bleeding patient with DIC, prolonged PT and APTT, yeah, in bleeding with prolonged PT and APTT, then you may find FFP to be useful. FFP should not be instituted based on lab tests alone, yeah, but should be considered in those with active bleeding or requiring invasive procedure. All right. Now, I have listed the complication, the adverse effect of transfusion. I am not going to go through. It's very self-explanatory, so you can read the slide on your own. Unless you have question to ask me, then I am more than happy to actually respond to the question. Okay, so do you have any question? I hope you don't mind, yeah? I won't go through, you can just read. Right. So do you have any question? Are you still around?
Yeah. I have a question. Haris here. I have few questions. The first one, regarding actually this question, since undergrad, I don't understand. What is the
lamanya simpan.
When we say about extrinsic and intrinsic pathway, what does it mean? What does it mean? Actually, why is called as extrinsic and why is called as intrinsic?
Itulah, doktor pun tak berapa nak tahu. Alright, I guess when you say extrinsic pathway tu, because you know you are talking about tissue factors tau. So tissue factor, blood, yeah, is not normally exposed to tissue factors. They are not. Alright, so the fact that when you need that particular arm of pathway of coagulation cascade to be stimulated, you need the tissue factors. So it's extrinsic to the blood. You get that? Yeah. But then you can argue with me, macam gitu, the intrinsic tu, the subendothelial surface also is not, the blood is not exposed to it. But again, you have factor 12 that stimulate the intrinsic pathway is already in the circulation. All right?
Okay. Second question is, why patients who having inflammation or sepsis, they will be anemia? What is the
itu you have to go to the pathogenesis of anemia of chronic disease. Yeah, although the terminology said anemia of chronic disease, but acute bacterial infection or acute infection are also included under that, because when you have this acute infection going on, you will have all these pro-inflammatory mediators being released, and this complicated network of cytokines can cause direct suppression to the erythropoiesis. All right, and peculiar to certain type of infection, they can also induce some degree of hemolysis. Right? So basically, when you want to work through infection and anemia, of course you kena tengoklah juga. Are you looking at infection with DIC juga? Kalau ada DIC, then you have to think of microangiopathic hemolytic anemia. But basically, if your question is directly acute infection and all that, you have to work through the mechanism of the anemia of chronic disease, although it's acute, right?
All right. The third question. Actually, after we transfuse PET cell or whole blood, when is the exact time we should repeat the FVC? I mean, what is the minimum time and what is the maximum time so that the value is reliable?
All right. If you were to go into literature, kalau rajin lah sikit, yeah, you look at literature, people have done all these studies, yeah. People have looked at after 24 hours, after 8 hours, after 8 hours. Semua tak ada difference. They cannot conclude yang dekat mana. So you just can do even after 8 hours, after 6 hours. Yeah, there is no effect. Although you want to think if you do earlier, you do not have the plasma volume to equate dengan red cell. Sebenarnya tak ada. So they have not come up with when is a direct moment. People have done all studies and they say you can actually repeat. Right?
Anytime. Alright, that's all my question.
Thank you. Lamanya simpan. Dari undergrad.
Okay. Is there any more question from the online audience or online participants?
Tadi Haris
Haris.
Okay. Doktor bila tengok dekat macam tak kenal lah pula.
Okay, I think there's no questions even from the online audience. Thank you very much, Prof. Najib, for the time and lecture.
Okay, all right.
Yes, all for today. And we'll see you back. 2 p.m. I hope we all can benefit from the session, and please pray for us to pass the exam.
Inshallah. You know, I always say when you have made the effort, yeah, and you pray to God to facilitate and make it easy, the rest you have to leave to Him. Yeah, you have no more control. All right. So have faith in Him. All right.
Yes,
Go got one more
there's
question.
one more question.
Dah, doktor dah ni dah.
In the IC, it is a systemic response. So the
Right.
thrombosis will occur in the microcirculation, means
Yeah.
in the capillary.
Yes.
So means in the capillary, bleeding won't occur there, and bleeding will occur in the artery, venous, vein, like that. Is it so? And that's why thrombosis occur in the in the capillary only.
Dia memang you see it, basically DIC is microcirculatory thrombosis. Yeah, we are looking at widespread microcirculatory thrombosis. We don't actually look at condition where there is widespread of venous or arterial thrombosis. Sebab kalau in arterial thrombosis, for example, you are looking at atherosclerosis, so you may have in the coronary artery, you may have in the cerebral artery, all right? But when you look at the causes, yeah, related to DIC, these are more causes when you talk about the pathophysiology. They are more systemic and generalized, as you yourself pointed out. Yeah, when you have infection, the pro-inflammatory cytokines, the inflammation is systemic. All right, so it exposes the microcirculatory circulation to the disease pathogenesis, right? So even bleeding is actually microcirculatory bleeding as well, because you can have in certain blood vessel, you can have thrombosis, in the others you can have thrombosis and bleeding going on concurrently. You understand? The cause is more generalized. Kalau you cakap macam contoh coronary artery atherosclerosis, so you expect the thrombosis to just occur at the site where there is ulceration of atherosclerosis. But if you're talking about infection, for example, septicemia, yeah, you are talking about septicemia. It's more of systemic response. Do I answer your question?
So means bleeding can occur in the microcirculation also.
Yes. Yeah. All right. Contoh macam kalau you look at acute promyelocytic leukemia, kan, is a very it's a medical emergency. Again, what is the cause? The cause is when the blast lies, the blast is in the circulation. When the blast lies, the blast release the granule, because promyelocytic has granule, and this granule act as tissue factor to activate the excessive coagulation cascade, yeah, to actually cause the thrombosis as well as the bleeding. The bleeding tu pun microcirculatory thrombus bleeding, when it's widespread, it causes a major bleeding lah. All right.
Okay, Prof.
Okay. Okay, dah.
Thank you for watching.
Okay. Assalamualaikum. Good afternoon. I wish you all the best. Kalau jumpa doktor kat koridor tu, tegur ya. Okay. Assalamualaikum and good afternoon.
Thank you, Prof.
Tadi ucapan.
We'll be back at 2 p.m. for the next lecture. So for the time being, lunchtime. Thank you.